Hello, everyone. I'm Song Yang. I'm in charge of the endoscopy marketing in Boston Scientific. Welcome to Boston Scientific Virtual Integrated Proctorship. So today is kind of the series of the webinar, and so that Professor Manson mentioned, but this is the like a starting journey. So we may have the more opportunity to have the interactive session between the Thailand and the Indonesia. So today's moderator is Dr. Parewangi Akil. So now she is already in the meeting rooms. Okay, just in case, I will just briefly introduce today's speaker, Dr. Thawee. He is the Department of the Surgery in Rajabisa Hospital in Bangkok in Thailand. He was like a Thai association for the gastrointestinal endoscopy. And also he's very active the member of the medical society. And also like he's a member of the American Society of the Gastrointestinal Endoscopy. So I think the before we started, Professor Manso, he is the director of the Wyden Hospital, will make an opening speech. And Professor Manso, over to you, please.
Thank you. Good morning. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam.
Welcome to the virtual workshop, Makassar Advanced Therapeutic Endoscopy, Endos, that will be held from June 15 to 22 and July 5, 2021. Of course, it's an honor to speak with you all today in this cordial meeting hosted by Center of Gastroenterology and Hepatology of Dr. Wahidin Sudirohusodo Hospitals in collaboration with Rajiviti Hospital, Thailand, and Division of Gastroenterology, Hepatology, Department of Internal Medicine, Medical Faculty, Hasanuddin University, Makassar, Indonesia. I would like to first say hello to all speakers and mentors and supervisors, as well as all participants. As we know, we're happy to announce that our Gastroenterohepatology Center at Wahidin Sudirohusodo Hospital is one of the excellent services. Therefore, it's important to always strive to improve knowledge and skills in the field of gastroenterohepatology. In the last few decades, we have continuously strived to improve our facilities. However, all of that means nothing compared to efforts to increase the competence of human resources. This workshop is part of continuous professional development and improvement. And I hope that this workshop will provide great benefits to all the participants and especially to our team at Wahidin Sudirohusodo Hospital in terms of improving the quality of services, especially in the field of gastroenterohepatology. And we know this time the workshop had very special value, you know, because the workshop is taking place on digital platform due to COVID-19 pandemic. But I think this also we have actually some benefits because we can invite more participants using Zoom link and etc. So as I said before, that this workshop not only this year, but I want we can perform regularly, become the annual workshop like that, because the development of science, especially in the field of gastroenterohepatology, very, very fast. And last but not least, I would like to thank to our partners, especially Boston Scientific, yeah, who support this workshop. And finally, because we actually want to hear very soon our speakers, our expert in this field. Finally, I would like to, by the name of Allah, Bismillahirrahmanirrahim, today's workshop I open officially. I wish everyone successful and safe, and the main is stay healthy because we are still in the pandemic, and fruitful workshop. Thank you. Wassalamualaikum warahmatullahi wabarakatuh.
Assalamualaikum warahmatullahi wabarakatuh.
Thank you very much.
Thank you. Thank you. Okay, Sanbo, I think Dr. Fardah is with us, already joined with us in the studio. So you can meet him with her.
Yes, noted. Yeah, please go ahead.
Yes, thank you, Mbak Suchang. Matet ya. Ya, Assalamualaikum warahmatullahi wabarakatuh. Good day and good morning ya, Prof. Thawee. Nice to meet you. Sorry it's late to be coming in this place. It was an honor to be having collaboration with you, Dr. Thawee, and please allow me to introduce some sort of briefing about our Center of Gastroenterohepatology, HM Akil, Dr. Wahidin Sudiro Husodo General Hospital, as a introduction to our collaboration here. And this is our place in Dr. Wahidin Sudiro Husodo General Hospital. And next, and we are having with the same place with our division of gastroenterology hepatology, Department of Internal Medicine, Medical Faculty, University of Hasanuddin. Next, please. As we know that Makassar City is a health referral center in Eastern Indonesia, and Medical Faculty, University of Hasanuddin as a center of our education here, and Dr. Wahidin Sudiro General Hospital as a hospital education center. This Center of Gastroenterohepatology, HM Akil, was planning built in 2004 and finishing built in 2008. The purpose of this center is for information, services, education, and research in gastroenterology hepatology field, and place for activity with division and other department in Medical Faculty, University of Hasanuddin. Next, the name of our center was intriguing because of there is our founding father in the field of gastroenterohepatology is HM Akil, And then not only in our field of gastroenterohepatology, but our funding father is having some short in funding too in our internal medicine and medical faculty. So it was our honor to have their name in our Center of Gastroenterology Hepatology. Next, we have in our Center Gastroenterology, we have 2 floors. This is the first floor. There is some polyclinic there, and our hall for our library and our meeting place there, and there's a secretary there. And the second floor is a place where is our services for endoscopy and gastroenterohepatology education and research we do. Next, please. We have a staff. At initial, we have 3 professors, and they all have already passed away. And at this present, we have 6 all consultant gastroenterohepatology with 6 nurse endoscopy. Next, and this is our endoscopic procedure. In year 2015, we already have a visiting patient in our center, about 9,000, and endoscopy procedure we have more than 2,000. And in the year 2019, we can see here that the visiting patient already going up in 15,000, and endoscopy procedure will go in 4,000 procedure. But because of COVID-19, in 2020, we have visiting just only 8,000, and endoscopy procedure 700. About the endoscopic retrograde cholangiopancreatography, we starting in the 2017 years, and this is the procedure that we already done in our center, about 500 more case. That's it. Thank you for your kind attention, all of their college and our distinguished guest, Dr. Thawee. Nice to meet you. And then, Dr. Thawee, do you have any a comment about our center here? Or
first of all, I would like to thank and express my gratitude to you and team to build up of the center. You can see in your presentation, you start, and then right now some more case and more case, and also the fast develop in terms of the endoscopy. Congratulations for your team, and hopefully it's more work we need to do together in the future.
yes, thank you very much, Professor Thawee, for your concern. Yeah, this our ERCP procedure was headed by Dr. Luthfi and Dr. Nukmang. This is our 2 staff is have a good, I think, excellent expertise here in ERCP itself, and me as a former of the head of division and center of gastroenterology, very proud of them too, and yes, and other my staff too. Probably. Okay, so we go to the next session about 2021 virtual integrated proctorship part 1. I think we have a three-part here, and our first about the overview endoscopy cases sharing at Wahidin Sudiro Husodo Endoscopy Center HM Akil. I will like to introduce Dr. Muhammad Luthfi Parewangi to present his cases. This is his curriculum vitae of Dr. I.M. Luthfi Parewangi. Now, Dr. Luthfi Parewangi is the head of Division of Gastroenteral Hepatology, Department of Internal Medicine, Hasanuddin University. Have education of graduate from consultant of gastroenteral hepatology in 2014 and doctoral program in 2015 with many more advanced training that he already go through, and I think it makes our ERCP here very advanced now. Please, Dr. Luthfi, you may present your case.
Okay. Thank you, Dr. Fardah, Akil, for the introduction, and also thank to Boston for the supporting of this meeting, this workshop, and also thanks to the director of the hospital, Prof. Mansur. It's very useful for the gastro team to practicing in this hospital, and also thank to Dr. Thawee for joining in this meeting. Firstly, I think you know this slide. This is ERCP, as we know. Firstly, we use for the diagnostic tools, but right now more uses for the therapeutic procedure setting. What we can do with the ERCP, we can use to manage the choledocholithiasis. I think we can manage the biliary and pancreatic neoplasm, for the stones, for the neoplasm, or for the post-operative patients. Also, we can perform by ERCP. This is Makassar team. I think Dr. Fardah, the former head, I think, and also Dr. Numan A.S. Daud, my partner in Makassar for the ERCP, and this is me. Firstly, we are using the this fluoroscopy room belongs to cardiology department. Firstly, because we have no special time procedure or place. We just go to the cardiac center and using their equipment at 5 o'clock or at 6 p.m. because we have no place. Just after training, we go back and look for many places that we can use to perform ERCP. And Alhamdulillah, the hospital give us many facility right now. This belongs to cardiology. Now it's COVID situation, as Dr. Fardah said, that the decrease of the cases is very, very big. This is teams, I think, from Makassar. Let me introduce. This is Prof. David, I think, from the Aikman. Dr. Fardah, this is Dr. Fardah, and Dr. Numan, kemudian Dr. Rini Rahmawarni Bahtiar. She can perform ERCP too, yeah, in Siloam Hospital. Dr. Amalia and Dr. Susanto. Yeah. Let me tell you about the clinical profile of the patient, the case that we found in Makassar from 2017 to 2021. The case firstly increased, but in 2020 it's decreased as Dr. Fardah said before. Yeah, and what we found in the case, mostly biliary stone, And the second one is malignancy, from the pancreatic malignancy, cholangiocarcinoma, also liver cancer. And the third one is also the ambulatory mass. And the third one is pancreatitis, yeah, pancreatitis. And it's maybe related to the biliary stone. And some cases, parasite, yeah, parasite. And also, this is the national insurance. Mostly the patient using national insurance. For the private, very small patient. So the supporting of the hospital and government is very important. And also, as we say, mostly from the charity room. Yeah, mostly from the charity room. Because the etiology is stone, most of the patient go back to the home with a good situation. Yeah, yeah, and getting better, and very small deaths due to the malignancy, mostly due to the malignancy. So what we are doing in Makassar? Sorry, many of my slides in Bahasa. I think no problem, Prof. Thawee. Yeah, a little bit you can learn Indonesian Bahasa. Yeah? We do scope insertion from the side view by using side view duodenoscopy. We do cannulation, many technique I think that many train. Sphincterotomy, precut, cholangiography, contrast injection, stone removal from the small stone to large stone. We are using basket, balloon retriever, and mechanical lithotripsy, simple mechanical lithotripsy. Also balloon dilatation, stent application from plastic to metallic stent. Yeah, even though the metallic stent is very small number due to the price, I think. Yeah. Wire guided, double wire papillotomy and precut we are using for the cannulation. We have a team, the nurse team. They are. This is very important, I think. The rhythm between the operator and the nurse is very important. That's why not just the doctor have to be learn and practicing more. Also, the nurse need to be in a good rhythm, especially for the cannulation. Yeah. This is a case in Makassar. This is a pancreatic mass. Yeah, pancreatic mass. So we insert the stent here. Yeah, the simple case, I think, due to the pancreatic. The number of pancreatic right now become increased. Maybe also the stone. This is the stone, the big stone. Sometimes we perform ERCP many times for just one patient due to the limitation of the facilitation. 3 to 4 times to bring out the stone, to remove the stone. Sometimes we are using basket, and after that we cannot remove all of the stone, so we put again stent, and in the next time we do it again. Yeah, this is because the limitation of the facility, the tools, the equipment, and so the accessories. This is also the cholelithiasis. I think this is simple. We have case the parasite ascaris. Yeah, ascaris. As you see here, this is by Dr. Numan. This case by Dr. Numan. On that time we work together. We insert the terbalik. We insert the wire and contrast, and after that, I think you can see the something inside.
Prof. Thawee, sorry, The video maybe
It's rotating. The feed is rotating.
upstairs. Sorry.
This is the angel angulation of the parasite. Then after that, this is this is cacing. Ascaris. The stone, this will be the stone especially. Many simple case, simple stone, the small stone. This is not difficult, I think, but also many difficult. The big stone, the big stone. We are using the ESG guidelines to remove the stone. For the simple stone, we just using the basket or balloon retriever. But for the difficult case, especially for the stone more than 1.5, but I think according to Prof. Thawee, 1.2 in your slides before I see, 1.5, multiple stone narrowing distal common bile duct or angel common bile duct. This is very difficult. That's why we perform many times. We remove some, and then in another time we remove another. So many times. I have some case 4 to 5 times to completely remove full of the stone. This is for the simple stone, I think, just using basket or using balloon retriever. But for the difficult stone like this is very big stone. We are using balloon dilatation and remove little by little until complete. I think this is several times we perform to completely remove full of the stones inside. That's why we are doing this workshop, especially for the product. I think Spyglass is very important. This is large tunnel PLBD. We also perform this one, but even we already have large tunnel, but we cannot completely remove the stone. Also, this mechanical, we have this one. Mechanical, but sometimes if we found the black stone, the basket become crushed and cannot be remove the stone. Cholangitis, many cholangitis case here due to the I think the food in Makassar, almost like in Thailand, mostly oily food. Also, we perform SIMS, self-expandable metallic. I think this is the product of Boston. This is the metallic stone we perform in Makassar. But the limitations, the problem, the limitation is equipment and tools, and also the accessories. Alhamdulillah, Prof. Mansur, the directors, available here, and can see that we need many special equipment and accessory for performing this. Then, and as we know, the complication of the endoscopy, just like bleeding, perforation, infection, sepsis, and death. So it have to be performed by the trained doctors, trained consultant. I think that's all my overview, what we are doing in Makassar. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Dr. Luthfi, for your complete presentation about our cases ERCP in Makassar. I hope Prof. Thawee we're glad to hear about our cases here because of sometimes it's very complicated cases. I think if we want to try treatment some patient with uterus obstructive, not only their obstructive itself, but we need to do their initial disease too or comorbid too, so they didn't go over through their another complication. Okay, Prof. Thawee, we go to the Prof. Thawee second speak. Itunya Prof. Thawee, kasih saya. Okay, next is Prof. Dr. Thawee Ratanachu the topic about biliary big stone and malignancy management. Dr. Thawee is from Department of Surgery, Japati Hospital. As a President Thai Association for Gastrointestinal Endoscopy 2012 and 2013, and a board member consultant of Upper Gastrointestinal Surgery of Thailand 2010 until present, and Gastroenterology Association of Thailand 2011 until present. Dr. Thawee is an international member too for of ASGE and Japan Gastroenterological Endoscopy Society. Please present your topic, Dr. Thawee.
Thank you very much. Can you see my slide?
Yes.
Yep.
Yes.
First of all, I would like to express my deeply thank for your team to invitations, and also to thank Professor Manso, Director Hospital, for give some words to open the meeting. I heard from you, Dr. Fardah and Dr. Lucy for presentation. I think this is a good, big success for your team to build up endoscopy service. As you know, I think every center for start endoscopy mostly start at 6 o'clock, 9 o'clock p.m. Mostly because we start with nothing first, and then to build up slowly, and then fasting as you done. I think it's a great job and congratulations.
Yes.
My talk, I got the questions. My talk to emphasize on the big stone and the malignant stricture. So we try to answer your questions. How about how to deal the big stone, how to minimize the complication, and how to get the good tissue in terms of the stricture to good manageable the case properly. Firstly, I would like to introduce Oral Cholangioscopy first. As you know, it's maybe 30-40 years back. We start with the Oral Cholangioscopy with the mother baby scope. At that time, it's very clumsy because we need 2 doctors to handle. I remember my first the doctor scope is a really big one. At that time, special mother baby scope. The diameter of the baby scope is up to 5 millimeters, a little big. And you can see on the left-hand side picture, also at that time it's a fiber optic scope. That very difficult. Same as your presentation, because at that time my facility also in the department of the radiology. I start ERCP first case mostly 5-6 o'clock in the same time. In the same time is we have no ERCP facility in my department. And then later on, Professor Wexman in Chicago and Dr. Yurakami from Japan tried to use ultra-thin scope, ultra-thin cathodoscope into the bile duct. This technique is possible, but you can see it's very difficult. Even you can use one scope, one doctor, but very difficult. And now I think Boston got the guest idea to build up the disposable cholangioscope. You see on my right hand slide, this is the first model of the Spyglass start in 2007 in my unit. This good in terms of the facility because just one doctor easily to insertion because the channel the diameter of scope just only the 10 French, like you put a 10 French stent. But at that time, the quality is acceptable, but might be suboptimal because at the time we use optical probe. So you can see, you can compare with the T technology. I think Oral Cholangioscopy right now more and more to use because easily to manipulation, for direction, and the channel is acceptable because of 1.2 and also really good in terms of the water irrigation. Right now, Boston have the third generation. It's digital quality. I will show you the image quality is quite good. Compared with the last one is 4 times resolution. The field wider and very easily. In the past, we need to prepare the optical probe. But right now, we can just plug in and can use it really easily. And to LED light, the image is quite good. As already mentioned, two channel of the water irrigation. And right now, Boston also to produce more accessory, not only for the laser ESL, and also the basket snare to remove the polymer. Or in difficult case, next time for the escalate, you can use the snare to remove escalates in the bile duct as well. So I think Spyglass right now is more and more in clinical practice every advanced endoscopy center, because you can see more in terms of interductal visualization. You can more target biopsy, and you can do more in terms of the intervention, especially stone. We give you more detail. I think this clinical application, you can see when you doubtful in the cholangiogram, you can put the scope in, you can see, you can get the tissue biopsy, you can mapping, you can see also clear when you cross with the lithotripsy. And also more in terms of the therapeutic, especially for the stone fragmentation. So we try to answer. The first question is how to break stone faster. I think I back a little bit when you pick up SPY, when you pick up a laser or ESL. So as Dr. Lucy gave a talk previously, this the candidate for the more difficult stone compared with the simple synctomy or basket or balloon. In terms of the size, maybe it's a 1.2 or 1.5 as Dr. Lucy mentioned. And more importantly, is distal bile duct size also important, because sometimes stone is not big, 1 cm, but distal bile duct only 5 millimeters. You can remove with a conventional technique. Of course, impaired stone, Bile stone in terms of the hardness, location in typic stone, this all difficult to remove, and also difficult to assess in terms of the circular anatomy. So I think in the practice from the stone, mostly we can use a mechanical lithotripsy, or if you have a ESML facility, also good one. And Dr. Lucy also mentioned about if you cannot remove, just put stent of course, you need to come back 2-3 months later on and repeat it. So that's why some difficult stone in terms of you can not catch the stone because maybe impacted, maybe it's no space. Right now, good option for the Spyglass to put in and break with the laser or SL. I think that's a good indication. I summarize the indication that you need SPY in terms of just maybe one single section or maximum 2 sections to break all stone. Mostly you fail from the lithotripsy because of no space. Also some stricture, some distal, or even the circular outer anatomy. What the weapon we use? Of course, you put a spy in, you can see. Right now, 2 options for you to use for the stone breaking device. The first one is a laser. In the market right now, I think the holmium laser, depend on your hospital. Firstly, I share this laser with my good friends, the department also use laser for the kidney stone, urethral stone, something. I think this is a good laser fiber. Right now, my center moved to ESL. I think ESL more convenient. Compared with the laser and ESL, depend on the number of the case. If you have more case, I think laser more efficient and also more cost effectiveness. But the number of cases not every week. I think ESL might be cheaper because the machine is cheaper. Of course, the ESL fiber is one single use compared with the laser fiber, but the machine of the laser fiber is more expensive. Right now, it's a laser fiber in the market is a holmium laser. In the past, in my unit, we use a lithonos. Lithonos is really good. I love this one, but right now it's not available. Why? Because lithonos right now, that time lithonos is fast lamp coumadin powder. This we call stone recognition system. The meaning of the stone recognition system is your laser fiber no need to touch. Just put in the bile duct and fill the water. Never injury of the bile duct. That's really good one. But right now, holmium laser is a combined holmium yak laser. So you need to perform under vision because the laser fiber can cause bile duct injury or bile duct perforation. So right now, holmium laser, ESL, you need perform under vision for the safety. And this will show you the setting. I think depend on the model of laser that you use, 20 watt or 30 watt. For the endoscopy right now, most of center move to the 30 watt. We try with the 100 watt, but no different. Mostly I think the 100 watt for the urology or for maybe for the orthopedics. But in endoscopy for bile duct stone, I think 30 watt enough. This setting, this proper setting for the laser fiber, and it's more detailed. Normally, it's the size of the fiber is 2 sides, 220 or 365. I think 365 is more effective, but more difficult in terms of the insertion. But for the ESL, it's more comfortable for us because it's a small class, easily to use and quite effective. We show you the short video clip on the left-hand side, ESL. On the right-hand side, is the laser fiber. At that time, it's 20 watt. I think right now, this both machine is quite effective to break stone. This study from Professor Yasuda in Japan and from the US group. These two techniques are I think it's quite comparable. So I show you one small case. This you can see this the malignancy syndrome. This difficult to remove with the conventional events mechanolytic because the stone occupy in the cystic duct in the common hepatic duct. And then this particular case, I think it's a good indication for SPY and with the ESL to break stone. I think this case may be 15 minutes because the stone is not too big, but difficult in terms of the location. And then we can remove stone. This is a multi-center study in Asia by Professor Amit Mayo from India and group. Also good friend from Asian doctor. You can see this 156 cases for the Spyglass with the laser and ESL. You can see the success rate for the first section is 80%. But on the right hand side, you can see. So the first section success depends on the size of the stone. If the stone less than, I think 1 section, less than 3 cm, 1 or 2 section. But if more than 3 cm is difficult in terms of the 1 section, you need more time. In my experience, maybe 2 to 2.5, maybe we need 1 to 1.5 hour. If less than 2, maybe 30 minutes, 45 minutes, we can break stone. Right now we use ESL is quite faster in our experience. Anyways, some small complication might happen, especially for the cholangitis and perforation. This also the systematic review of the 24 study to confirm the SPY with the baking device good. You can see the stone clearance up to 95% of the case and 6% of the complication. The second question, how to bake stone faster? I think if available, I think Tandan maybe can arrange the machine for you and try to collect the case that difficult for you to break stone, and you can get more experience and confident to use this technology. And hopefully in Makassar, this excellence center, also you can build up the more advanced for the patients. How to bake stone faster? The number one, I think because this laser or ESL, we need the water, especially saline water, to transmit the power or the power to the stone. So you need to fill with the water, and when you fill with the water, minimize in terms of the air moisture as well. This is really important. Mostly, if not available or not prepare the SPY, mostly the patient refer to you with the stent. My recommendation, when you remove stent, you need to clear small stone slot first, because the small stone slot make you more difficult, more time to break stone. You need to clear view first, and then easily for you. The number two, proper setting of the laser fiber or ESL. Maybe if you case for the second, third section, we guide you how to set the machine. And basically, my tip to make it faster, 3 techniques. The first one, you keep the laser or ESL just only 1-2 millimeters, not too far, not too close. 1-2 millimeters is good length to maximum of the power. The second one, you break from the center first. When you break from the center, the third one, more importantly, when you break, my suggestion to move laser or ESL fiber a little bit. When you move laser fiber or ESL, the power increasing, that make a faster stone breaking. That's the technique. And also dealing when you break the cloudy from the pre-drop stone, assistant nurse will aspirate to remove the small fragment out from the aspiration pot. The second one, how to minimize complication. Already mentioned the first complication for spy or when you break stone because you increase the volume of the saline in the bile duct and you put the laser or ESL to increase the pressure. The pressure, the volume increase the risk of the infection. So the timing is really important. Not perform in acute situation of the cholangitis should be avoided because it's some bacteria inside. When you increase the volume, you increase the pressure, of course you increase risk of the infection. So you need to keep the proper the antibiotic prophylactic and cover after the procedure. Use a small volume, so you need to adjust the volume. You keep the volume in the bile duct, but not too much. And the assistant, the nurse, maybe some aspiration to adjust the volume to adequate volume, just to clear view for the laser fiber. That really important to minimize in terms of the infection. The second one, perforation. Number one, how to avoid to clear view. Clear view important. So when you fire one by one, not continuously. When you fire the first one, you keep clear view. Second one, third one, fourth one. Yeah, clear view very important to minimize in terms of the bile duct injury and also to make more effective to break stone. The second one for the spy, I recommend to half block. When you half block, the tip of spy is more stable. Not move too much. It sometimes move too much and maybe accidental. The tip of the spy or tip of the laser or ESL into the bile duct and cause the bleeding and also perforation. And the third one already mentioned about the embolism. Be careful. In my unit, our general recommendation always use CO2 insufficient and fill with the water or saline in the bile duct. And the last one, I think this might be more importantly to avoid the scope damage. So you need to keep the tip of the laser or ESL at least 5 mm away from the tip of scope. That's really important because the laser or ESL produce the heat or the power might be cause the nature of the right is the damage. So you lost the money. So I think that this really important to safety for the spy scope because the spy scope not cheap, but I think it's effective if you properly use. The sequence problem is stricture. So for the Spyglass, previously the Boston to produce the first spy bite. This is the first spy bite, And right now, the second version of the SpyBite Mac, you can see the open jaw is a little bit bigger. You can get more in terms of the tissue. I will show you this video. You can see this SpyBite. You can see, you can see the really good scrap of the lesion. This papilla tumor in the bile duct. This cholangiocarcinoma. The second one, how to collect the good sample. I think I will answer this to the number one. You need to see the mass, because normally in the bile duct, the bile duct was really smooth one. If you found some protrusive area, that's a good target one. More importantly, you need to see the mucosal. The normal mucosal is really smooth, but the tumor is a little bit maybe more irregular. And most importantly, is the tumor vessel. The tumor vessel is, you can see the really dilated tortuous vessel. I think that the good area to target the biopsy. I think that this is really important. Anyway, in case that already placed the plastic stent, might be a little bit difficult, but you can still see the good target area with the target, the tumor vessel or irregular area. That's a good one to take the biopsy. I recommend to take a biopsy from the above to the below to minimize in terms of the vision. This compare is to divide 3 divide to get the tissue from the bile duct. This conventional the cytobut from the conventional ERCP. This the biopsy forceps. You can use regular biopsy forceps or standard biopsy forceps under fluoroscopy. But right now, from the spine, you can use a spine by Mac under vision. The benefit, you can precise to get the tissue under vision. The question is, the sample big enough? I think this study to show you, you can see the comparative study. This the comparative or the O1, the first generation, the spy by with the conventional biopsy forceps. The first trial in the luminal first and then to the bile duct. You can see even the piece of the specimen is smaller than the standard biopsy forceps. You can see just 1.5 millimeter compared with the 2 millimeter by average of the biopsy specimen. But anyway, in terms of the processing, no different. And in terms of the result, also no different. Even luminal or the bile duct. And you can see even the 1.5, but you can see all the good structure. That's why this is very effective. If you see the literature roughly up to the 90%, you can get the accuracy from the tissue diagnosis. And also recommendation by Professor Cham Dalawarajulu from Florida. One of the good benefit, if available for the cytopathologist in your center, you can use rapid on-site evaluation. Same in case of you perform the imprint of the lymph node, the same one, the same technique. You combine with imprint, you can get more in terms of the accuracy and more faster and more decided to put the plastic stain or metal stain in terms of the advanced malignancy. So this, I think this is one step to give you idea how to manage in case of the advanced cancer in the first section. The third question is difficulty or not to take the biopsy, especially intrahepatic, and I put on in very distal lesion. So my first answer, intrahepatic, especially for the second order or in the branch, left, right anterior, right posterior, might be sometimes difficult in terms of the difficulty of angulation. Because when the angulation, you can get the first bite, but second bite is sometimes difficult because difficult to pass the spine bite into that area. My technique, we put the small wire first. As you know, is the spine scope is the up to 10 French. So if you keep one more wire, should be small wire, or 1.5 or 0.18 or 2.5 only, and you keep the pillow spine first and get the guideline from the wire to the target area. That's one of the technique that you can use in difficult case, especially in deep intrahepatic bile duct. You can see the list study from Japan, because as you know, it's in Japan standard of care of the cholangiocarcinoma. The mapping of the cancer is really important for them. So in this particular study, to confirm that the Spyglass can give a good result in the intrahepatic bile duct, you can see even in the B2 conjunction is you get more than 90%. In conjunction between right and left right posterior, right anterior, right posterior also can get close to the 90%. That to make you confident that even in diabetic bile duct also you can get a good in terms of the specimen. For the distal bile duct, I will show you the technique how to get the distal bile duct. You know, it's the very distal bile duct is sometimes difficult because of the stability of the scope. This particular case, the 50-year-old female, the patient with jaundice, really dilated the bile duct from CAT scan. We show you later on, and jaundice, and you can see the bile duct, big one. This intrahepatic bile duct really dilated, and down to the ectabetic and to the ampulla level. But the MPD is quite normal. Might be this ampulla tumor or very distal bile duct tumor. But for the ERCP, you can see it's quite normal shape of ampulla. Incision the guide wire, catheter, make cholangiogram, cannot see any tumor. You can see, put scope in to see more distally, cannot see anything. But small, you can see small, really small taper, very small taper there. And then decided to keep the wire in and put the spine. This the ERCP view, this spine view. Put spine in, and then in this particular case, I cannulate spine with the guide wire. You can see when you slowly to put in, this very distal area, you cannot find any tumor. You can see very smooth. Yeah, very smooth. There's not any tumor. This is one of the technique to see the distal. You need to fix the spine scope up under the guide wire and keep in more stable position. You can see more clearly in terms of the distal duct. I think this one good to answer. In this particular case, no cancer. So in my summary, I think the cholangioscope, one of the powerful tool for you, especially in the advanced endoscopy center. As you already mentioned, if you know spy, maybe you need to repeat that procedure, and maybe some intermediate stricture difficult to handle. It's benign or malignant. I think this is the power to help you to take care of the patient properly. I think this is one of the good option for you to develop this technology. And I will finish with this short publication. This from US last couple of years. You can see spies give you more in terms of the clinical impact. As already mentioned, for the stone, for the big stone, for the stricture. I think this is one of the great device for you to take care of the patient in pancreatic diseases. Thank you very much. And right now, as a director said, in this pandemic COVID-19, difficult for us to travel. Also, I think hopefully you can learn this in this I make in the YouTube in our EC channel. We just launched first FC US series in English version this week, and next week we will keep ERCP series. Hopefully you can visit our channel and enjoy this presentation. Thank you very much.
Yes. Thank you. Thank you very much, Dr. Thawee, for your interesting speaking here. And about your tips and tricks using a spyglass and how to treat all of the case of hepatopancreatobiliary disease here. It is interesting speaker. Very much, Dr. Thawee. Okay, we move to the question and answer session. We have many participants in our virtual meeting here from a few islands in Indonesia, Dr. Thawee. There is Dr. Asaki from Aceh. There is a Dr. Masrul Lubis from Medan. There is Dr. Didi from Semarang. There is Dr. Sinta Murti from Kalimantan, and there is one from digestive surgery, Dr. Dwicha. All of our colleagues is from Dr. Asaki, Dr. Masrul, Dr. Didi, and Dr. Sita is consultant of gastroenteral hepatologist. So if there is any question from the floor or anybody participant in this webinar virtual, please. Dr. Sandro have a question.
Welcome and thank you very much for you to join this wonderful Makassar workshop meeting. I'm really happy to respond any question in endoscopy field, especially for the hepatobiliary diseases endoscopy.
Yes, thank you, Dr. Thawee. There is a question from Dr. Santo here about first question about if there is any pressure control accessories to avoid high pressure when using spyglass.
Basically, for the Spyglass, you can use water irrigation system, water pump. My recommendation to use low pressure first, low rate of the pressure, and then you adjust by assistant freehand water irrigation. If you use the water pump is high pressure, might be increase the pressure in the bile duct. It's more in terms of the complication. I think you just start with the low pressure first, and then you slowly increasing, and maybe additional with the manual irrigation or put the water in with the water aspiration port.
Okay. Thank you, Dr. Thawee. Next question about if there any marker for of the laser 5 millimeter, a marker of the laser 5 millimeter. I don't.
Normally, laser fiber right now have the blue sheet. The blue sheet. When you use a laser, recommend to cut the tip of laser first. Every time you start, you cut the tip of laser. If you cut the laser, it's more effective. And you keep the laser fiber, the bare laser fiber, 2 millimeters from the blue sheet. And then when you put the laser fiber outside the spine, you can see the blue sheet. You can see the blue sheet, and you keep the blue sheet and tip laser fiber 5 millimeters away from the spine tip. Always you need to see the blue chip, the blue sheet for the fiber. Very important.
The blue tip.
Yeah,
blue tip. Okay, thank you, Dr. Thawee. Another question is it possible the spyglass could enter the gallbladder, Dr. Thawee?
In the gallbladder?
Yes.
Yes, definitely. Because depend on the wiring, you need to put the wire in the gallbladder first, and you inject contrast, and you need to evaluate the cytic duct first. As you know, the cytic duct normally cytic duct is only 3 millimeters, or smaller 3 millimeters. So I think depend on the size of the cytic duct. If the cytic duct is size more than 4-5 millimeters and stone, you can put the spy scope over the guidewire, and you can put in. Mostly the spy scope for the gallbladder to break stone at the cytic duct. That's a good indication.
Okay.
Yeah, because sometimes the cytic duct stone cause the malignancy syndrome, that you can break stone this area, or sometimes you can find some filling defect in the cytic duct. You can more clearly seen from the spine to make sure is any tumor or not. I think my answer is the possible, not difficult. Put the wire in to check the size of the cytic duct, and then over the guidewire.
Okay, thank you, Dr. Thawee. Another question. Can stent put after laser the severity of bile duct perforation? From Dr. Sinta, can we put stent after we doing the laser?
Population, yes.
To lessen the severity of the bile duct perforation, Dr. Thawee.
I encountered one case of the laser fiber perforation from the trainee. And that particular case, because as you know, when the laser attack the wall and perforation very small, hole. And you see, it's some bleeding. You see some bleeding, and you some small hole. You just stop. You remove all the fluid out, and then you insert the wire, and you put stent, and you give proper antibiotic. No problem. Because if you recognize, no problem. But if you not recognize, might be some problem in terms of the increased list of the collection. So already mentioned the spy for the laser. Every fire need to see clearly view. That's really very important. Not to rush, just one by one, clear the view, fire, clear the view, fire, one by one. My answer is yes. Just put the stent in, fasting, keep antibiotic.
Okay. Thank you, Dr. Thawee. Another question is how safe to cut the sphincter in distal tumor case, Dr. Thawee? According to your experience.
In terms of the symptomy, right?
Okay.
The question is to cut sphincter for insert the spine, right?
Yes. Is it possible?
Yeah. Normally you can make a standard symptomy. You can make standard symptomy and put the spine in, because Spyglass is only the 10 friend catheter. But in some particular case, if you already dilate with a big hole, with the large balloon dilatation, it's sometimes difficult to keep the water inside. And that particular case, you need nurse need to be more in terms of the fill the water in. But in this particular case, be careful of aspiration. Be careful aspiration. That's really, really important.
Yes. Yes, thank you, Dr. Thawee. So, according to the last question, there is some question continue about that. So, how big the lumen diameter of CPD we can use the spyglass, Dr. Thawee? Because some of you say that the more bigger the lumen, it's very hard to filling with the water.
Because the spyglass are 10 friend catheter, so the bile duct more than 10 friend, that more than 3-4 millimeter. But if the very dilated duct, for example, the very dilated duct, difficult in terms of the control the tip, because the tip moving. If duct is really dilated, the tip moving easily. So in that particular case, when you see, for example, the 3 cm stone, and you can find stone, and you make a half block at the tip of the spine first, because if you half block, the tip move really difficult. That's why you fix the tip of the spine close to the stone. You can see the stone, and then you can bake stone. If you not half block, sometimes the tip spines move far away and difficult to find the stone. So good position, half block, and see the clear view, and fire for the big stone. And already mentioned, keep the laser fiber at least 5 mm far away from the tip of scope. Really, really important to save your money.
That's the good point. Yeah, sentences, Dr. Thawee. Saving money.
I have one vision.
Okay. If there are any question, can be directly to asking Dr. Thawee, please.
Luthfi, I wanna ask you about. You said that spyglass can crash the cystic stone, it's been just like Merisi stone. How far we can entrance to the bile duct or to the hepatic duct for the spyscope?
Basically, spyscope can go into the anterior or posterior bile duct, or to segment 2, segment 4, segment 4, segment 3, segment 2 bile duct. But
how's the cystic duct?
Cystic duct as well. So depend on the size. I already mentioned depend on the size of the cystic duct. I think the spyscope with laser or ESL is really good in case of the malignancy syndrome. That's really good indication.
Okay. As we know that according to the size of the stone in the cystic, the GB gallbladder,
Yes.
less than 0.5 can spontaneously migrate to the CBD. If we found the large stone in the GB, can we crush using this equipment?
You mean break stone in the gallbladder, right?
Yes, Dr. Thawee, a big stone in the gallbladder, and we're using spyglass to remove the stone. Is it possible?
I think the stone in the gallbladder, not our job. The stone in the gallbladder is surgeon. It's surgeon.
Okay.
Agree.
Yeah, I think that's the last point.
Yes, we agree. All of us is agree.
As I see in your case, in the small cancer in the distal of the CBD, I see that you cutting the ampullary. How safe we cutting the sphincter in case that there is tumor inside?
Basically, when you see the ampulla, you should observe the suprapapillary fold. The suprapapillary fold is mostly we call the maximum location of the sphincter that you can cut, or where you need to see the suprapapillary fold. If you cannot see, in some case you cannot see very easily, you put the symptom over the guidewire inside the distal bile duct, and you bore the symptom. When you bore symptom, you just pull back. You can see the suprapapillary fold. Or sometimes you can use the retrieval balloon. You put the retrieval balloon over the guidewire, and then you bore the balloon, and you pull back the balloon, attack the distal bile duct. When you see the attack the distal bile duct, you can see really clearly of the suprapapillary fold. That's the maximum sphincter that you can cut safely.
Okay. Thank you for the tips. Very important tips. One more, Dr. Thawee, about the stricture in the CBD. Can we use this spyglass like we are using APC?
Spyglass for what? For
Together.
It's like APC. APC we can
argon plasma coagulation. Dr. Thawee, is it
you mean a stricture?
See with spyglass?
Stricture or narrowing due to the malignancy, yes, or cicatrix.
In the case of yeah.
You mean you can use spy to treat stricture, right?
Yeah.
Right now, spyglass. Right now, the technique of spyglass, just to see to get the tissue biopsy, the number one. For the therapeutic, right now we just the laser fiber to break stone, of course, for the break to coagulation or to ablation the tumor, in the technology right now cannot. We have no device to make it because we have no ABC under the spine. We have no the long yak laser. You can see holmium laser, holmium yak laser is for the stone breaking device. We do not have the pale yak laser. Pale yak laser can ablate the tumor. But pale yak laser right now, the fiber is a very short one, not the long one. But for the percutaneous, right now, Spyglass have the short spine we call the spine discover. The spine discover you can approach by percutaneous. In that particular, you can put the short yak laser inside the spine discover to ablation the tumor. So right now, my answer is for the ablation tumor, just only the spine discover under the percutaneous approach, not per oral approach.
Thank you, Dr. Thawee.
So, Dr.
Yes. There is a question about laser application. Two questions. In the case of a big stone with cholangitis or acute pancreatitis, when we should start laser, Dr. Thawee?
In terms of the acute cholangitis, basically is if you keep antibiotic and then you need to perform ERCP. The first ERCP, you just put stent or nasal-Bile inside to control infection first. When you control infection, maybe it's in the same, maybe 4 or 5 days later on, you can come back. Because at that time, the first, number one, you already control infection. The second one, you already cut the sphincter to open.
Yes.
That I think really safely to perform at that time.
Okay.
Wow,
Thank you very much, Dr. Thawee. Another question. After metal stent application in CBD, is it possible to do laser application?
After stenting?
Yes, metallic stent, Dr. Thawee.
Okay.
Yes.
You mean in malignant tumor on, and then you put the metal stent and then stone inside, right?
Yes, right.
Yes, definitely you can do it because
Okay.
if you put a stent, the stent is good with, because a stent is really big one. The big channel is very easily to insert spine in, and you can break. But the water, you need to keep the water.
Yeah.
Because the water disappears very fast. So the water volume is really important. You need to keep the water.
Okay. Okay. Thank you, Dr. Thawee. Is there any question from a participant? Dr. Bibi, Dr. Azaki. Hello, how are you?
Dr. Sinta.
How are you all? Dr. Masrul?
Good.
Hello, Dr. Sinta.
Cinta, what a case you did this morning.
Yes.
Okay, please, Dr. Sinta. If you have any question, another Another question. Dr. Seta already have a question for Dr. Thawee just before.
Yeah. Yeah, laser is very important for a big stone, but also I found that it has a lot of scary complication, Achan. I have one patient with perforation of bile duct after I've done the laser, and after it's really give me a trauma. So I feel a little bit worry when I do a laser now. So, you know, yeah, I need more practice in doing the laser. Yes, I'm really afraid of the bile duct perforation from the laser.
So as already, thank you very much, Chinta. I think as already mentioned, not too last to break stone. You just need step by step to care view. The care view really important. You need to care view and file step by step. Sometimes you fire continuously. When you break stone, fragmentation make it cloudy. You cannot see anything. And the second 5 seconds short, third thought maybe the cause injury. So I think it's very important to step by step.
Yeah. Okay.
And Achan, as you know, maybe Dr. Fardah, so I once have a case of my trapezoid stuck in my patient bile ducts. And Prof. Thawee know because at that time I do a consultation with Prof. Thawee. Yeah. So Prof, now, of course, every operator after have some complication of their patient must be feel worry when they do another ERCP. So my question, Prof, ERCP on a big stone, special will asking. Can I break the stone or not? Can I break the stone or not? So my question, Prof, can we predict which stone might be difficult to be break by our tools like the trapezoid?
Okay. Using trapezoid, Doctor. Yeah.
So in terms of the microlithotripsy, the shape of stone, if the shape of stone is square stone, square shape, number one is difficult in terms of the hardness. The number two is radio opaque. If radio opaque, that means hard stone. These are two criteria difficult to break. Anyway, you can try. So when you cast stone and you start to break, the metal tip will move up. When you slowly to rotate or to crush, the metal tip move up slowly, move up. If your assistant crush stone and the metal tip not move up, Thawee, stop. If your assistant to crush Thawee, the metal tip is not moved up, that means the stone too hard. You stop and you release the basket and you put stent on. If your spine not available, just put stent on. If you more cast, your basket will broken. Please remember, you can try, but if your assistant to cast, but the metal tip not moved up, stop and release the basket. That's the way safety in terms of the less complication.
Thank you, Prof.
Yes. Thank you, Dr. Sinta, for the question. Next question from Dr. Masrul Lubis. This is our college from Medan. If we found a big stone in CBD, which one modality Dr. Thawee use? Laser or shockwave lithotripsy?
In my unit right now, we use ESL, and sometimes we use a laser. We use both ESL and laser. I use ESL shockwave only the tumor on the stone in the posterior segment. Right, posterior segments are very difficult to put the spine into break. At that particular case, I put the nasal-biliary tube because most in diabetic stone is lithotripsy. You cannot see from the follow. We just put the nasal-biliary tube and we keep the patient. My machine in the operating theater, I sedate the patient. I inject the contrast under follow through the nasal-biliary tube to locate the stone, especially for the light posterior stone. And then we set the machine for ESL to shockwave. That's one of the indicators in my unit for the shockwave lithotripsy. But mostly we use ESL or laser to break under spine.
Okay, thank you, Dr. Thawee, for your answer.
I have one question, Prof. Thawee. I have several cases. The complication after cholecystectomy. After cholecystectomy, the patient come with the jaundice, and when we are performing ERCP and injecting the contrast cannot go up to the communicist duct. So there is no access to the proximal side of the bile duct. Can we use spyglass in the case or any other modality? How you treat the patient like that?
Thank you very much. It's a good question. For me, number one, I make MRCP first because this particular case might be the complete cut or the clip. So we see MRCP first. If MRCP is really directed in diabetic duct and lot of segment, that means might be complete cut. Normally in complete cut, in my unit, we see the length of the complete cut. If the length less than 2 cm, in my unit right now, we use magnet. We use magnet to recanalize. Yeah.
Yes.
So in this particular case, we put the PDPD first. And we put PDPD and we keep PDPD 10 friends 2-3 weeks, and then we come back. We use one magnet under PDPD and one magnet ERCP. If less than 2 cm, it's possible to use a magnet to recanalize. Anyway, if complete cut, no magnet, it's difficult. The second scenario, if the patient previously is a leak, if patient leak and then control the leak, and then you come back after ERCP, MRCP is might be short stricture. So when you perform ERCP, ERCP and you inject the contrast under pressure with the balloon. If you some streak of the contrast go in, but your wire cannot go in. At that situation, you can use SPY to assist cannulation. So SPY is the low SPY in this particular case only when you perform ERCP with balloon occlusion. You can see the some contrast into the bile duct. At that particular case, you can use SPY to assist wide cannulation. It complete, no contrast. Mostly we cannot use SPY in.
Okay. I think I will show you one case. Can I share? Oh yeah, okay. I think this one case. You see the case?
Yes.
As you see here, firstly, like this, you cannot access, even though this small one. Alhamdulillah, in this case, we can access to the proximal side. As you see, that the contrast can entrance to the proximal side, to the right and left. But the wire cannot entrance far to the proximal. On that time, I just put the stand until here, and it's work. I have not the next slide, the next ERCP, but in this case, just until here, the stand cannot access to the proximal. Maybe in the fourth time, we can access the proximal. This is just one case. But in another case, totally cutting here and cannot access to the proximal. And the MRCP blown dilatation of the proximal side, just like this one. Actually, this is case because we can control, but in another case, we cannot access to the proximal. How's your comment, Prof. Thawee?
I think, thank you, Malignant. This is a very good case. The number one, in this particular case, I will start with the occluded cholangiogram first. If you occluded with balloon and you inject more dye, maybe you can see more clearly. The number two, you can see the tip of the Y. You can see the floppy tip of the Y still inside the angulation. So in this particular case, I will use a true tome. I will in your case, you can see you cannot advance the sphincter tome inside. So I try to rotate my tooth tome and try to more insert the Y deeply first, because the steep part still too below. I think if you can keep more steep part inside, you more success.
Okay. Jadi
okay.
tipnya.
As you see here, I'm using balloon. I think this is 3 to 4 millimeter balloon, but this is not work.
No.
You see
I
here?
think this balloon not work. The first one, you need to keep the steep part of the Y inside first. You can see the steep part of the Y, not inside.
Yeah,
inside
right.
Just the floppy part.
Correct.
Yes.
This is the
the floppy part. Yeah. Yes. If the floppy part like this difficult, you cannot succeed. So next time, try to use a tooth tome and rotate and keep the steep part inside first.
Okay.
That's really important.
Yeah. Rotate it to the left side or right side.
Right now you can see when you put the catheter in at the tip, you can see the tip part of the hard Y. Yes, and then you rotate back to the right side.
Right side. Okay.
Right now, and you rotate back right side and you inject the contrast. When
It means that rotate to the right side and then pull back.
Tidak, kasih masuk kembali lebih dalam. Ya, kita rotate baru kasih masuk katanya lebih dalam.
Making an angel and rotate to the right side and pull back. Is that
when you rotate to the right side and you try negotiate the Y again, and you keep the tip sphincter going down. If you see it going down, you can negotiate the Y up.
Okay.
Please try again next time.
Yes, thank you, Dr. Thawee, for your instruction here. This is a very complicated case that Dr. Luthfi have. Is there any question from the participant? There is one question from Dr. Rini about using a spyglass for therapeutic for tumor in CBD in the future and beyond, like cutting the tumor. I think Dr. Thawee already explained about it, but please explain again, Dr. Thawee.
What the question?
Spyglass for a tumor in the bile duct, is it applicable for cutting the tumor?
No. You mean in terms of the to ablation the tumor, right?
Yes.
To ablation the tumor is right now cannot under spy because we do not have PLYAC laser. We don't have the argon. But in particular case, if you want to cut through, you can use right now we use six-fen cystotome. You know cystotome. We use six-fen cystotome. Just or you can use right now in my unit for cholangiocarcinoma. We use a half beam radio frequency IFA half beam. That's very good one. You can use the half beam IFA by Boston Scientific. I think this is one of the good to update the cholangiocarcinoma.
Okay. Yes.
So, Dr. Lucy?
Yeah.
So in your particular case, I think if you try the second one and you still not succeed, I will send one magnet to you.
Oh, thank you very much.
This is a very good candidate for the magnet.
Magnet here.
Yeah.
Thank you.
Thank you very much, Dr. Thawee, for your support. Actually, I want to ask you about the magnet because we don't have it any of that one.
Last couple of weeks, I sent one magnet to Dr. Vincent in Singapore as Dr. Hinda friend. I will send to you. I will send to you in this particular case. I think it's a really good candidate for the magnet.
Yes, yes, agree, Dr. Thawee.
I think Boston will
facilitate
the
delivering.
Yeah.
Is applicable for Boston? Okay, thank you very much. I think if there is any more question from participant.
Yeah.
We have a few minutes more.
Oh, Dr. Azaki, I think I have a question.
Dr. Azaki, do you have any question for Dr. Thawee? You can directly answer. Directly asking Dr. Thawee. Dr. Asaki.
Dr. Sinta.
Dr. Sinta.
Prof. Thawee, do you have a slide showing about that magnet? I really want to know about that one because I never saw any.
Okay, I will make you can into the this month. This month is video JE. You can put a video JD in the website. And this month, our team with Chulalongkorn University, we put the one magnet case of the complete obstruction.
Okay.
We perform the US guided hepaticostomy and one put the magnet from the Therapeutic to the Therapeutic, and one magnet from ERCP. You can see this video GIE this month, just only released this month.
Okay.
Okay. So there is a video about demonstration how to using magnet.
You can visit video GIE this month. Just released this week.
Okay. Thank you very much.
Okay, thank you very much for your
information. I still have one case. I want your comment about this case. I think this one. Is it clearly see? In this case, this is the big stone. Yeah, this is not really big, but the proportion of the stone between the stone and the distal part of the CBD not proportionally. You see the distal is narrowing and the size is not too big of the stone, quite same with the scope size. But I still try to applying the balloon dilatation. Do you agree with these decisions? That's the first question.
No, I do not recommend for the balloon dilatation in this particular case because this normal bile duct, this normal small bile duct. When you use the balloon dilatation, maybe you increase list of the perforation and bleeding. Two options for you. The first really good option, you put one fully covered stent, one fully covered 6 cm Warfix stent, and then you cut stone, and you can treat stone, and also you can treat the normal small bile duct. The second one, you put a multiple plastic stent first. You put multiple stent to make a small distal bile duct a little bit bigger first. Small gradually increase the size first, and then you break stone later on. In this particular case, you need to increase the size gradually, not balloon.
Okay, but the price of the metallic stent is very high.
Yes. Or the second option, you can use a multiple plastic stent.
Multiple plastic stent.
Yes.
So periodically dilated by plastic stent, right?
Yes, same. You can see this cholangiogram might be very similar with the in case of the chronic pancreatitis.
Yeah.
The same morphology, the same figuration. You can increase the multiple stent to increase the bile duct first, and then you remove later on. Yeah.
Okay, thank you, Prof. Thawee. I think in the third meeting, I think we will share many cases like this, and your comment is very important. for this proctorship part, I think.
Part.
This is just pemanasan, warming up, I think.
Warming up. But in this case, Dr. Luthfi actually finally is doing ballooning to this patient. And what about the condition of this patient, Dr. Luthfi?
After dilatation, God bless us, there is no leakage.
Bleeding? What about bleeding?
After that, the stone can come out. So I decide to crushing by using the lithotripsy, mechanical lithotripsy. After lithotripsy, still the stone cannot pass the narrowing side of the CBD. And after that, I just putting the stent and leave the patients in the next session, I think.
Okay, so the patient go to the next session, have a second session,
preparation for the next session.
Okay.
Yeah.
Okay.
You can try again. Really good. You can try again and put a multiple stent next time. But you can cut.
Yeah. I hope Pak Tandan will bring us metallic stent in this workshop.
Yes, Dr. Thawee, thank you for your support. Okay. Is there any question from the participant that attending here? Because I think yes, we now have a end of this session. The time is already end, and yeah, yes. Okay. Mr. Sambo. Mr. Sambo from ASEAN Zoom. If you ever have a or
yeah, I really appreciate so I would like thanks to Professor the Manso for the very insightful opening, and also this is the like a first journey of the our like a learning continuum. So this is the like a good momentum. So we Boston Scientific, we will provide qualified this event for our customers. And also today's speaker, Dr. Thawee, and I appreciate it. And the Dr. Lucy is very practical cases and is very happy to understand what is current challenge. And also, sorry, Boston Scientific point of view, we also provide more meaningful a training session and how we can solve this kind of the technical challenge. And we are just willing to support. And also, Dr. Padan, I really appreciate your a moderator session for the Q&A, and also I really appreciate. And also, thank you for the all the attendees today. And we know that we are just suffering from the COVID pandemic, but we will try to overcome this unexpected situation. And Boston Scientific, we also provide meaningful a support to our customer and including patient.
Okay, thank you.
Thank you very much for the team in Wilderness Hospital, and I think it's a great team. Congratulations for your hard work to improve endoscopy service. Also, thanks Sungbo for Boston Scientific to arrange this program. I think we can join together in the future.
Thank you very much for your support, Dr. Thawee. Yes.
And also thanks the Indonesian team, Cinta, friends, colleague.
Dr. Asaki, Dr. Didi, Dr. Masrul.
We will meet in the next week in the live demo session.
Yes, so I would like to announce that there is a second part of virtual integrated proctorship in Tuesday, 22 June 2021 2021. So I hope all of our colleagues here that participate in this event will continue to together in this our next Makassar Advanced Therapeutic Endoscopy 2021. And also I would like to thank you to Boston Scientific to making our event here in collaborated with our center and the hospital of Dr. Thawee and division of gastroenterohepatology. And I would like to say thank you for Professor Mansur Arif for attending our meeting here until the end. Professor Mansur is represent our director of Dr. Wahidin Sudirohusodo Hospital. And thank you to Dr. Makbul Aman, PhD, our head of our Department of Internal Medicine, Faculty of Medicine, University of Hasanuddin, that attend until the last minute too. And especially to our college here, I would like to thank you that your contribution in this event will be valuable to enhance skill and knowledge of our college in the field of advanced therapeutic endoscopy, especially in Indonesia. So thank you again very much, Dr. Thawee, Prof. Mansur, and Dr. Mabul for your support here. And we will end of this session with Alhamdulillahirabbil alamin. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Thank you, Mas.
Thank you, Dr. Thawee, for your support. Please always support our team. Okay, I enjoying the workshop today. Thank you for all. And let's leave the meeting.
Okay.
Dr. Luthfi. Dr. Luthfi.
Sebentar, Mike. Oh ya, bagaimana Dokter Sinta? Apa kabar?
Jadi yang kasus yang menggunakan smart glasses-nya minggu depan ya?
Ya, pekan Selasa depan, insya Allah gabung lagi ya. Kita live dari sini.
Saya menunggu-nunggu smart glasses-nya nih.
Oke, kita juga menunggu smart glass-nya. Itu kan buat kita bagi-bagi. Pak Tandannya.
Kita yang di ujung pulau nggak ada temennya.
Biar bisa benar-benar share dengan baik.
Ya, siap minggu depan. Terima kasih
Ya.
Dr. Fardah.
Ya, sama-sama.
Dr. Nasrum.
Saya izin Luis.
Nasrum belum pernah bicara.
Ya, Dr. Sinta, terima kasih partisipasinya. Dr. Nukmang, terima kasih. Dr. Amelia, Dr. Susanto, Dr. Ini. Dan saya punya adik-adik PPDS, terima kasih ya bantuannya semua di acara pada hari ini.
Videonya luar biasa.
Ya, ya.
you.